Bismillahirrahmanirrahim. Bismillahirrahmanirrahim, respected audience. Today, our special guest of speaker is Professor Kamran Muhammad Riaz. He is a clinical professor at Thelma Gaylord Endowed Chair in Ophthalmology, Dean McGee Eye Institute, Stephenson's Refractive Eye Surgery Center. Professor Kamran has got almost 90 publications to his credit, and he is co-author of 20 books. He has also written a special book and author of the optics about New Millennium. This is a very good book for the residents training. Today we have requested Professor Kamran to present his talk on new vessels growth on the cornea and the new modality about the use of intravascular mitomycin injections into the cornea. So I will request now Professor Kamran Muhammad Riaz to kindly present his talk.
Thank you, Dr. Mirza. Thank you, friends, for joining this recording. My name is Kamran Riaz, and was mentioned in the introduction, I'm faculty at the Dean McGee Eye Institute. And today we're going to be talking about a problem which is a very well-known problem, which is corneal neovascularization, which has some solutions thus far that are used in clinical practice, but as we know, continues to be a problem that is very challenging, very frustrating to both clinicians and patients alike. So without further ado, we'll go ahead and get started here. So these are my financial disclosures, nothing related to the talk I'm about to give. Corneal neovascularization, as you know, is a major cause of corneal blindness. The latest study, which was more than almost 30 years ago, 1.4 million patients worldwide, but we know that this is probably likely increasing and continues to be a very commonly encountered problem. Corneal neovascularization, we have to remember, is a response to several etiologies that can happen in the eye. There are certain things like trauma, ischemia, non-infectious etiologies, but the most common cause is going to be infection, and specifically viral keratitis with herpes simplex, herpes zoster. And so when the eye tries to deal with these pathologies in the cornea, then new blood vessels will form. And vision loss can occur to any of the following causes: lipid deposition and scarring, irregular astigmatism, loss of corneal clarity, and either concurrently or subsequently, we can have loss of corneal sensation leading to a neurotrophic corneal state. Before we talk about corneal neovascularization, let's take a step back and talk about why do blood vessels normally not form in the cornea. We have to remember that the cornea has what is called angiogenic privilege. There are a number of mechanisms to prevent corneal neovascularization, such as the corneal anatomy, where we have tight arrangement of collagen lamellae due to stromal hydration. The cornea has lower corneal temperature compared to body temperature. And there is a presence of soluble and cell membrane-bound molecules which work to inhibit angiogenesis. And finally, there are low levels of MMPs, or matrix metalloproteinases, which cause and lead to corneal neovascularization. So the normally low levels of this help to prevent corneal neovascularization. However, when there is an insult to the cornea, the normal cornea relies on an equilibrium, a kind of a state of tug of war between anti and pro angiogenic factors. But when there's an insult, it leads to a pro-angiogenic state, and that leads to a proliferation of various factors, including VEGF, which then lead to a vascularized cornea. When that happens, we get vascular endothelial cells that migrate towards these stimuli. These form new lumens and branches, and leads to new vessels. So interestingly enough, when it is in the acute or very early stage of neovascularization, these vessels are dependent on VEGF, and this is where anti-VEGF treatments, whether it's injectable or topical, work best over here. But when there's persistent inflammation and there's a rebound release of VEGF, then we have persistent corneal neovascularization. And as we'll talk about in a little bit here, this is where in the chronic or late-term state, anti-VEGF treatments do not work well because these vessels are no longer reliant on VEGF. Let's talk about some of the findings that we see clinically with corneal neovascularization. So here in the top left panel here, we see a combination of these soft lipid exudates. These are sort of these pale, whitish, almost cotton wool-like lesions here, which are not light blocking. And then we typically also see these hard lipid exudates represented by the arrows. So when we have vessels, we see both soft lipid exudation as well as hard lipid exudation. So this is something that we're going to be talking about when we talk about treatments, because the hard lipid represents these denser, more compact lipids. This is described as sort of the bar of soap appearance. And we'll see that there's often a combination of soft and hard lipid exudates. We can see corneal neovascularization here. This is a patient who has previous corneal transplant, and we can see that this vessel crosses the graft-host junction and branches into the cornea and primarily has soft lipid exudates. We can also see sort of the connecting loop of vessels from either side of the cornea here. In this patient, this is mostly predominantly soft lipid exudates. And in chronic disease states, such as chronic PKP rejection, we can see multiple fronds of corneal neovascularization arranged both circumferentially as well as radially that cross the graft-host junction. So these are different types of vessels that we can see when we have corneal neovascularization. This is sort of a nice picture here because it really is important to show the superficial KNV vessels. These are these black arrows here. These are often seen in other disease states like rosacea blepharitis, severe dry eye, and they are described as these fine, wispy, very fragile vessels. And as we'll talk about some of the treatments here, these are not very amenable to injection. Now, in this patient here, we also have these deep vessels here. This is stromal neovascularization. You can see these pale, they're kind of juicier, they're fatter, they're thicker. And you can see that these vessels are the ones that have both the soft and the hard lipid exudate that are seen at the leading edge of the deeper vessels. Because of the size and the fat caliber of these vessels, these may be amenable to injectable therapies in terms of cannulizing the vessel directly. So it's very important, I think, as clinicians to be able to tell the difference between these superficial and deep vessels and accordingly direct the treatment depending on what type of vessels that we see. This is just another picture of deep corneal neovascularization. Again, we can see sort of this loop of vessels starting here inferiorly, reaching up into the visual axis, but we can see how it's connected sort of in this loop. And then on the slit beam, we can see how deep these vessels are in the stroma with some perhaps fine superficial corneal neovascularization vessels off to the side. So we have these deeper vessels that go into the central part of the cornea, and these superficial vessels would stay off to the side. How do we diagnose corneal neovascularization? Well, obviously clinical exam, including serial photography. So here's a patient here in the top left panel, very early stage of lipid keratopathy with minimal corneal neovascularization. And 1 year later, this is the same patient because we can see that there's an iris freckle and iris nevus here, very profound, very significant, deep corneal neovascularization with both soft lipid and hard lipid exudates here. Within 1 year, this patient got much worse. And we'll see this patient here later on. But there are some newer technologies such as using fluorescein, ICGA, OCTA. These can all be used here. There is obviously a cost and technological barrier that all practices, all clinicians may not have availability for. But these are nice to show here. In this picture here, we can see that the vessels clinically look like this. So certainly we can see there's both superficial and deep corneal neovascularization. But then on fluorescein, we can see that there's significantly more vessels that are readily appreciated with the naked eye here at the slit lamp. And this is probably a very nice example of vessels which seem very fine, very wispy, almost may seem like they're insignificant, but then on the imaging here with fluorescein, we can see how much these vessels actually fill with the fluorescein. These are just more pictures here of showing on what this may look like on the slit lamp. Here we have a ghost vessel, which can be seen a little bit better on retroillumination. But we can see here that on OCTA, they actually are not shown. They don't light up because these don't have active blood flow. So kind of a nice way to differentiate between active and inactive vessels here with some of these different technologies. We can also use anterior segment OCT to assess things like stromal compaction. Sometimes when these vessels form, we get compensatory epithelial hyperplasia, as we see here in this picture here. And it's also very important to check corneal sensation. Many of these patients may have either concurrent or subsequent corneal neurotrophic disease. And this is very important to help stage the disease and also monitor the response in these patients, and also to determine that if there's concurrent and significant neurotrophic disease, that certain treatments may not work as well as other treatments. This is sort of a nice table here that shows all of the medical therapies that are used for treating corneal neovascularization. Traditionally, topical and injectable steroids have been used, but there's very little evidence that these reverse corneal neovascularization. These, again, work best in the early state of disease when there's active inflammation that is happening. So steroids may work to halt or prevent new vessels from forming, but they unfortunately don't work very well to eliminate or reverse corneal neovascularization. Anti-VEGF treatments have gained a lot of interest in recent years because of their use in other areas of ophthalmology like retina and how well they work for treating neovascularization. These work, again, very well in the early disease states of corneal neovascularization. But just like as we know from retina pathology, that multiple injections are needed, otherwise the recurrence rates can be very high, so up to 40%. And these can be used both as topical anti-VEGF, injectable VEGF, and then there's some other treatments in the pipeline here with other anti-inflammatory medications that are targeting other cytokines. As we can see here, there's a laundry list of various treatments here. And then some off-label medications, such as using cyclosporine to treat inflammation and dry eye. Doxycycline can be used because it does inhibit MMPs, and as we talked about, when in an inflammatory state, MMP 6 and 9 are upregulated, and so using that as an adjunctive therapy can be used. But ultimately, these work well primarily in early disease states, but don't do too well to reverse or treat existing corneal neovascularization. This is a picture here of showing the effectiveness here of topical bevacizumab here, patient here with prominent neovascularization and associated scarring here. And this was corneal neovascularization that was secondary to herpes zoster. And these are slides I should have actually given the credit here to Mohammed Desjurdi, who's in New Jersey, a friend of mine who was very kind to share these slides here. But you can see that there's a good resolution here of these vessels. There's still some of this lipid scarring and keratopathy treatment, even after treatment there. In this panel here, we can see this is corneal neovascularization of failed PKP, and a very prominent, very appreciable resolution of some of this neovascularization here. And while this patient may not see a lot better, this may at least make the corneal surgeon, feel a little bit more confident and comfortable doing a repeat keratoplasty, given that the vascularization has improved significantly. We move on to some laser therapies. Argon laser, YAG laser have been used. Photodynamic therapy can be used, and these can be used in combination as well. And again, these work well for active vessels and vessels that are amenable to be hit here. Surgical therapies, of course, vasodestructive treatments like cautery is still very, and fine needle diathermy So cautery and FND are very economical and very effective options that can be used, especially for superficial vessels. But they may be a little bit difficult to treat for the deeper vessels because of applying heat to the deeper levels of the cornea. But these work very well, especially for vessels that form peripherally in failed corneal grafts, and especially if the surgeon is now considering repeat corneal transplantation. Suture ligation, and there's also now some role for perhaps using corneal cross-linking. There's one paper that kind of talks about that for repeat keratoplasty. And of course, the definitive treatment that is often used, though it does have high risk of failure, is corneal transplantation, either PKP or DALP. There's some recent papers that have showed using endothelial keratoplasty in these cases, but that may not treat the active disease process and really treats the posterior cornea. And as we saw, that a lot of these vessels are in the stroma, so the endothelial keratoplasty may not have as much benefit here. Ultimately, though, we know that high-risk factors like corneal neovascularization, the effectiveness and the success rate of corneal transplantation significantly goes down. This is a case here showing using both argon laser and subconjunctival bevacizumab combo therapy, how much improvement there was at 6 weeks. But then at 4 months, we can see that there is recurrence there, with that treatment strategy there. So let's move on here to now talk about the limitations of existing therapies. Well, why don't therapies that we currently have work well for these chronic and late-term corneal neovascularization cases? Well, the reason is because within 2 weeks, most of these vessels are covered by a cell called the pericyte, which we may remember vaguely from medical school when we've studied the vascular system. But once the vessels are covered by pericytes, what happens is that the pericytes block the corneal neovascularization vessels in a blanket. And more importantly, these vessels are no longer dependent on VEGF for survival. So this is why injecting anti-VEGF medications or topical anti-VEGF medications don't work well on these deeper vessels or these chronic vessels, because they are covered by pericytes and they are no longer dependent on VEGF for survival. So this is why suture ligation and fine needle diathermy still work well, but topical bevacizumab does not work well because these vessels are no longer dependent on anti-VEGF here. So again, this is just showing here that these vessels are covered by pericytes. So it's really obvious that we need to think outside of the box and think, what else can we do to treat these chronic neovascularization type of corneas here? So this leads us to the topic of intravascular chemoembolization. And this is the idea of using pharmaceutical agents to destroy blood vessels. And mitomycin C, as we are very familiar with in ophthalmology, for using in refractive surgery after PRK, using for glaucoma surgery with trabeculectomy. But mitomycin C for chemoembolization has been used for various tumors, such as liver cancer. And what is very attractive about mitomycin C is it can permanently block the repair capacity of blood vessels. And the key word here is permanent. So unlike bevacizumab and anti-VEGF medications, which may work temporarily, mitomycin C offers it being a pharmaceutical agent that can permanently and irreversibly treat corneal neovascularization. So can we use mitomycin C to halt and destroy existing vessels and also prevent new corneal neovascularization from happening so that it is an irreversible treatment? And this is an idea that actually we have to give credit to Dean Owano, who's an ophthalmologist in North Carolina, who came up with this idea of using mitomycin to chemoembolize corneal neovascularization. And what is, I think, a very landmark paper published in 2022, he described using 3 patients that had lipid keratopathy and corneal neovascularization that was encroaching the visual axis. It's important to understand that these patients had failed conventional therapy like antivirals and steroids. So this was not a first-line treatment. These are patients that had failed conventional therapy. And what was very interesting about this paper is all three patients had full resolution of their corneal neovascularization. There was improvement in the lipid keratopathy, both the soft and the hard exudates. But most importantly, none of these patients had complications or loss of best-corrected visual acuity. So these first three patients, then when this was shared on the worldwide corneal listserv, inspired many of us, including myself, to rapidly adopt or at least explore this modality as a very effective treatment for corneal neovascularization. So who is a good candidate for mice? I think this is very important that we understand who's a good candidate, because not every patient with blood vessels in the cornea is a good candidate for mice. So, who is a good candidate? So patient with lipid keratopathy, secondary to corneal neovascularization, that is encroaching on the visual axis, right? So in other words, we don't want to pick a patient that has those fine, wispy vessels that are more common with like a rosacea blepharitis type of a case or a limbal stem cell deficiency type of a case. Those are not very amenable to cannulization, and those don't typically have lipid keratopathy associated with the corneal neovascularization. So we want to find vessels that are fat, and we want to find vessels that are leaky, right? So those are the two key characteristics. We want to find vessels that are fat and vessels that are going to leak lipid and have started to leak lipid into the cornea, both soft and hard lipid exudates. And number two, we want to make sure that the etiology is very well controlled. Again, many of these patients have herpetic eye disease, so treating them with oral acyclovir, valacyclovir, topical medication here to make sure that the viral load is treated. These patients often have concurrent lid margin disease and dry eye, so making sure that this is under a stable state and there's not active dry eye going on. And that leads us to, we want to make sure the eye is quiet and uninflamed. So if we see lipid keratopathy in the context of perhaps active herpetic disease, which also has anterior chamber cell and flare, we want to make sure the eye is treated and quiet with steroids before we subject the patient to surgery. And this is why I think a failed trial of topical steroids is very important to demonstrate that the neovascularization is not responding to conventional therapy. As far as preoperative planning, getting slit lamp photos, ANSEG OCT, topography, tomography, checking corneal sensation, all of this is going to be very helpful. Let's talk a little bit about the injection protocol. It's very important that we use a very thin gauge needle, a 33 gauge or a 34 gauge needle with a luer slip, not a luer lock. It has to be a luer slip type of a system here. Do not use a 30 gauge or a 32 gauge. This is going to be too big. And it's very interesting now, having done this for the past 2 years, sometimes you see these patients at the slit lamp and you think, oh, it's going to be very easy to cannulate this when you have the patient under the microscope. But sometimes you'll be surprised how even what you thought was a very fat vessel, and even when using a thin needle, how the vessel is even thinner than you think it really is. So it's very important, I think, to find a very thin gauge, a 33 gauge or a 34 gauge needle, and not a 30 or 32 gauge. This is going to be too big. People always ask, well, how much mitomycin should we inject? If we inject at a concentration of 0.3 or 0.4 mg per ml, we want to really inject about 0.01 to 0.05 ml. I mean, it is very small amount. So the maximum amount that's going to be injected is going to be about 0.02 milligrams. And this can, I think, alleviate some concerns for safety, since we are injecting this medication into the eye. We want to aim for the largest corneal vessel that's inside the limbus. So try not to go at the limbus, but actually slightly in front or anterior to the limbus. Once the vessel is cannulated, the surgeon needs to use enough force with a low angle of penetration. And we want to look for a flash once we're inside the vessel. And when treating it, usually 2 or 3 treatments for the vessel of interest is sufficient. And we want to look for the blanching of the vessel to demonstrate that it's worked. And some patients may require, of course, repeat treatments depending on if the vessels recur. This is a video that's actually Dino Wano's video here. I like to show this because this, I think, is one of the first videos, that we know of. And this kind of shows the cannulization of the vessel. Notice he's kind of curved the needle, which makes it a little bit easier. So that's a miss, right? So you see here, there was a miss there. We got corneal emphysema. Probably we're a little bit too superficial. Here now is going to be a hit, and this video is slowed down, and we're going to see Dr. Owano threading through the stroma, reaching a point where he's now gotten to the vessel of interest. And now when we see there's going to be an injection here, we'll see the blanching of the vessel that happens here. You can see it's very rewarding. And here's another hit where, again, he's going to go from a different side, find the vessel, and ideally you want to find like a flash of blood in the cannula, in the needle lumen there, and then injecting to get that actual hit there. What can we expect? Well, right after mice, we may see some blanching and ablation of the vessels within the first week. First day to up to the first week. And then after the first week or so, we can get the so-called pizza pie sign, right? So we can see this blood and lipid trapped within the corneal stroma, which looks like a pizza pie. So this is something which can be very prominent visually, can make the surgeon maybe a little nervous or afraid to see this, but this is very normal about 1 to 2 weeks later. And about 1 to 3 months later is when the all of this lipid gets absorbed. So we can see here, we get absorption of lipid, and there's some stromal compaction which can happen. And this is important because this can cause some astigmatism for the patient, and can cause some irregular astigmatism as well too. This is why the taking preoperative tomography is very helpful, and the anterior segment OCT can also show that and demonstrate that. So what is the role of mice for corneal surgeons? I think mice can be used as a primary therapy as well as a precursor therapy. As a primary therapy, what I mean by that is to treat the corneal neovascularization and perform visual rehabilitation with glasses, contact lenses, and avoid any further surgery. This is the ideal scenario. But we can also use mice as a precursor therapy where we can treat the corneal neovascularization to set up further surgeries down the road, whether it's cataract surgery, corneal transplant surgery. So this is very important, I think, for surgeons to kind of think about this as both a primary as well as a precursor therapy. So let's show some examples here of using mice as a primary therapy. This is a patient who presented to us, had an open globe repair done at the end of 2022, so about 2 years ago. We repaired the patient's open globe, had multiple corneal lacerations, and 3 months later, we can see that there's significant corneal neovascularization extending here inferiorly. The best corrected visual acuity had dropped to 20/50. So in April of 2023, I took this patient for mice. So this is my surgical video here. And I wanted to show this video because it actually shows the first attempt was a miss. So we can see that probably was a little too superficial at the first attempt. And it's very common when doing this because we're always naturally nervous because we don't want to be too superficial. So notice that the first attempt is going to be a miss. We'll actually see some corneal emphysema here. I thought I was in the right space, probably right about here. And I'm going to inject. And we'll see that it's sort of a miss here. Okay. So we realize we're not in the right spot. So we're going to come back a second time here. And now notice there's a flash of blood in the lumen of the needle. And now when we inject here, we're going to see a good blanching of the, there we go. You can see good blanching of the vessel that tells us that we were in the right spot the second time around here. So, and then again, this is just another repeat treatment at the same time. So again, you want to treat these vessels about 2 or 3 times. So that's probably an example of both a little bit of a hit, but we had a little bit of a miss because we had some emphysema over there. And then this is the third treatment that's done at the same session there. Again, we'll see some good, there we go. We can see some good blanching there, and you can see the mitomycin following the course of the vessels. So that's that case. And then, so 1 month later, this is what the patient looked like. Notice the pizza pie cornea there. And then 2 months later, we see some continued improvement of the blood and the lipid there. We can also see some stromal compaction that's happening as this is getting treated here. This is 2 months after mice here. This is again showing the patient how, the stromal compaction. We can see the changes in the epithelium here versus in the central of the cornea. But now 6 months later, we can see the same patient and the lipid continues to be resolved. There's a few vessels here off in the periphery, but that prominent frond of neovascularization is completely gone here. Again, this is on thin slit. This is on direct illumination. This is on sclerotic scatter, just showing different views of this to show that these vessels have indeed regressed, even though there is still some scarring that's there. And then this patient was fit with a hard contact lens and was able to achieve 20/20 vision 6 months later. This patient did come to see me here in April of this year earlier. And again, we can see this is 1 year post mice, still has maintained 20/25 vision here. And we can see on these different views here that the vessels continue to remain regressed here with very minimal scarring that is left behind in this patient's eye. This is a second case here of a 78-year-old female with history of zoster that started in 2016, slow onset, slow development of corneal neovascularization, vision dropped to 2015. We can see there's 2 prominent areas of neovascularization. Again, here is the surgery of this patient here. Again, you can see the flash of the vessel there tells us we're in the right spot, and we can see some treatment and blanching there of the vessel that happens there. We can kind of skip ahead and go show treatment of the other side here as well. So again, we can see good blanching, and then we can see again the injection of the mitomycin following like the tree branches of the various branches there of that vessel that happened there. So this patient again, 4.5 months later, almost full, full resolution here, and a good resolution over there of that neovascularization that we saw. This is a third patient here. This is a patient who had PKP for keratoconus in June of 2021. And then about 2.5 years later, presented with corneal neovascularization, crossing the graft-hose junction. We can see this prominent vessel, which was kind of extending into the graft-hose junction. Visual acuity dropped to 21/25. We can see it's also causing quite a bit of astigmatism there in this patient's eye. So we went and did mice. And this is 2 weeks later. We can see the pizza pie cornea here on the direct illumination on sclerotic scatter. We can still see some of the ghost vessels, but we do see quite a bit of the blood and thunder, the lipid, the blood and the lipid trapped there. And then this patient 1 month later, again, continues to improve here. And then we see 6 months later, has improved quite a bit. And the astigmatism now is an acceptable about a diopter and a half. And he's able to get 20/60 vision here without, and that's just in glasses. I think with contact lenses, the patient saw even better here. Now 7 months later, this is the patient again, visual acuity 20/60, but most importantly, showing you here that even though this vessel has maybe started to come back a little bit, it has not grown into the graft. It's sort of stayed, and the vessel that has come back is perhaps very superficial and very wispy here. So again, we'll see how this patient does, but at least here for 7 months later, this patient has done very well. This is just a magnified view here of that same patient. We can see there is some maybe fine wispy vessel, but that deep vessel is completely gone here. This is another patient here, was seen in June of 2022. This I thought was very prominent. I offered her treatment, but she did not want any treatment. She felt she was seeing fine 20/40. And then she comes in here about 18 months later, and we can see that this same vessel has dramatically gotten thicker and fatter, with now both soft lipid exudate and hard lipid exudate. Here we can see corneal thickening and stromal thickening on the anterior segment OCT. The visual acuity dropped to 2070. We went ahead and did mice, and here 5 months later, we can see this is the improvement here. Visual acuity improved to 2040. This patient did not want any further treatment. We do see there are still some of these superficial vessels. So again, mice does not do very well for the superficial vessels. It really does well for the deeper, kind of fatter, juicier vessels. That's where the mice is going to work the best, as a treatment here. Here's another case. This is a patient who had 20/60 vision. Again, these vessels were very fine, wispy. There was both soft and hard lipid exudate, but because these vessels were very small, we decided to observe and not do anything further. This patient then comes back about 6 months later, May of 2021, and notice these vessels have become quite fatter. We have both the soft lipid and the hard lipid exudate, and it is encroaching into the central cornea. The vision had now dropped to 20/125. So May of 2021, we did mice on this patient here. We see here now 1 month later, or 3 weeks later, excuse me, we can still see there's a little bit of subconjunctival hemorrhage there, but very significant improvement. I'm going to go back and show you here that this is what those vessels look like. And then 1 month later, we can see significant improvement of the vessels. The light blocking effect of the soft lipid that we saw here, now we can see there's only partial light blocking effect. We still have some of the hard lipid over here a month later. And then about 6 months later, we can see that even this continues to improve, and this has nearly gone away, and the patient's vision had improved to 20/40. This is another patient here with corneal neovascularization here with previous PKP that was done in January of 20. This was seen in January of 2023. Best corrected visual acuity was 20/50. We can see now this frond of neovascularization crossing the graphitose junction and the soft lipid exudate encroaching almost into the corneal, into the center of the cornea here. And we can see on sclerotic scatter a better appreciation of these vessels and what they kind of look like. We see the astigmatism that is now induced by that vessel that is growing here. So we went ahead and did mice in March of 2023. And then 2 months later, we can see that there's good resolution of the neovascularization. There's still some lipid that we see here, but that vessel is nearly gone. And then by July, this patient had improved to 20/30, was able to wear a scleral contact lens 20/20. But the reason why I wanted to show this case was this patient then comes back in April of 2024 and now July of 2024 and does have some significant recurrence of this vessel and also maybe even some vessels from growing over here. So this patient then, we ended up doing a repeat mice in August of 2024, so very recently, just about 4 months ago. And here we have pictures of this patient, 2 months later, and we can see again good resolution of those vessels here, both inferiorly and temporally. So the learning point here is that some eyes may need multiple treatments. So this is one of my few patients I've had to do a second treatment for. I think I've only repeat treated 2 or 3 patients, but I've now done about 25, 30 patients now that I've not had to repeat the treatment, only done 1 treatment. So, but again, just to keep in mind that some patients may need multiple treatments, and just having that conversation with the patient and setting the expectation accordingly here. I'll skip this one here for the sake of time, and I want to talk maybe a little bit about using mice as a precursor therapy. Okay, so enough about using mice as a primary therapy. Let's talk about using mice as a precursor therapy in the time that we have left here. So this is a patient who's actually the mother of an optometrist. We can see this vessel is kind of growing here. It's extending into the visual axis. We can see the leading edge of the lipid. The visual acuity is not too bad, 20/40, but we went ahead and did mice. Again, notice 1 week after the mice, the hemorrhage that's there here near the limbus here superiorly. There's still quite a bit of lipid that's there, but then 3 months later, we can see there's good improvement here. The vessel is completely gone. The lipid there is good improvement here. She has a cataract as well too. So we went ahead and did cataract surgery on her, and noticed she had quite a bit of astigmatism, but it was very regular astigmatism. So I went ahead and did cataract surgery on this patient. We were able to place a toric lens in this, and she wanted a monovision target for the left eye. So we did cataract surgery on her, and actually she had a very good result here. We can see ended up 20/25 in that eye that we did mice, and had a good monovision result there. So the learning point here is that we ended up doing mice in order to set this patient up for successful cataract surgery several months down the road. Here's probably my favorite case, a very dramatic case of a patient here. This is a patient who I showed early, and I said we're going to revisit this patient. Had a little bit of corneal neovascularization with lipid keratopathy. Actually treated this patient with some subconjunctival triamcinolone and even did some argon laser therapy. So this was February of 2021, a month later. The visual acuity was 20/30. So the patient didn't want any further treatment. So we decided to see the patient back in a few months. And, you can see that this wasn't too bad. But the patient, life got busy, did not come back, and actually comes back almost a year later. And again, this is the same patient. You can tell the iris nevus here. This is the landmark here. And we can see a very prominent corneal neovascularization. This was due to herpes simplex, with the soft lipid as well as the hard lipid exudate here, pretty much covering the whole visual axis, and visual acuity had now dropped to 2400. So we went ahead and did mice in February of 2022. We can see the pizza pie cornea there, a few weeks after the surgery. And then May of 2022, so March, April, May, so 3 months later, we can see good resolution of those beefy corneal vessels, some resolution of the lipid, but the visual acuity was still only 20/200. So we went ahead and actually did a PKP in July of 2022. Here's this patient after the corneal transplant. Again, we can see a little wispy vessel out over here, but it has not crossed the graft-host junction. And then the patient developed a cataract by January of 2023. So we went ahead and did cataract surgery. And this patient ended up here at last follow-up about a year later. We saw this patient and was still doing about 20/40, 20/30 best corrected with a very minimal refractive error. We actually published this in the American Journal of Ophthalmology case reports because it was such an interesting case. But this shows how this patient, we used mice, not that the vision significantly improved by doing mice, but by doing mice, we were able to get rid of the corneal neovascularization, quiet the eye down, and set ourselves up for cataract surgery, corneal transplant surgery, and then subsequently cataract surgery, and deliver this patient a pretty good outcome, all things considered here. Again, this is just another patient who was referred for cataract surgery, had quite significant corneal neovascularization. We went ahead and did mice here. We can see good resolution of this in January, and then 3-4 months later, we did cataract surgery. Patient ended up 20/40, but still had quite a bit. This is the case. It ended up 20/40 here. This is another patient here, which was sent in March of 2023. Again, you see that double loop, that vessel loop of the corneal neovascularization with quite a bit of irregular astigmatism. We can see here what we did. I'll just kind of skip some of this. We already saw the video here, but I'll show just another video showing again how to do this procedure. It does take time. You have to be very patient. We can see here, the first time we'll actually miss, right? So the patient moved, so I had to kind of come back out. And the first time, again, I'll show you here that and you see me talking to the patient, trying to tell her not to move because it is under topical anesthesia. So here I thought I was on the right spot, but I'm going to end up getting some emphysema, right? So this is patient This is quite a bit of emphysema there. So this is a miss, right? So this is showing, you can see the patient moved, but I also am not in the right spot. So we wait for that to kind of clear, wait for the blood to kind of resolve here. And the second time around, I'll show you here that we get a much better access. And now we get the flash, so I'm in the right spot. See the flash? And we can see that we have a good treatment there of the vessels there. So this patient, again, 1 week later, we see that, again, that pizza pie cornea appearance that was seen there. This is 1 month later. So again, we see improvement that's happening of the lipid keratopathy and the neovascularization. And 2 months later, we can see that there is almost full resolution of the vessels. There is still quite a bit of corneal scarring left from the hard lipid exudate. We went ahead and did cataract surgery 4 months later using sort of assumed Ks. We set, because the Ks were so irregular, we went ahead and did just using 44.5 as the assumed Ks, placed a monofocal IOL. And we see here there is some recurrence maybe of some of those vessels off to the periphery here. 7 months after mice now and 3 months after cataract surgery. Again, thankfully, we don't see any of those vessels in the center of the cornea in any of the views. We do see some vessels out over here, but this patient's vision was not very good. So it does have, quite a bit of irregular astigmatism, which then worsened by November of 2023. So January of 2024, we went ahead and did a corneal transplant. And here's the last follow-up in October of 2024. We can see that the vessels have now, continued to stay back. We did inject some Avastin at the time of the corneal transplant for this, but more importantly, none of these vessels have grown into the center of the cornea, even though there are some vessels that are kind of out over here. So the final thoughts is that corneal neovascularization, I think, remains a challenging problem to manage. Early diagnosis and treatment with some of the historical treatments can have some success, but it may only be partial or limited success, and there may be a high rate of recurrence. Mitomycin intravascular chemoembolization, aka MICE, is a newly introduced procedure for this problem, and I think we can use MICE as a primary or a precursor therapy, though some patients may require multiple or alternative therapies. So thank you for the time and attention here. I'll stop the screen share, and hopefully we can take some questions and some answers here from Dr. Mirza. And yes.
Prof, thank you very much. You explained it in very detail in the videos. Of course, it is a new treatment modality and showing very good results. I just want to ask Professor Kamran that before starting this mice in your patients, do you have any special protocol to give a course of oral doxycycline, topical steroids? If it is your protocol, how long you give that trial to prepare the patients? One question is this, Prof. And second is, if the mitomycin gets into the anterior chamber, how it is going to affect the endothelial cells?
Yeah, so both excellent questions. Let me answer the first one. So for all of these patients, I keep them on oral antivirals. So usually I just use Valtrex 1 gram daily. I prefer Valtrex. It has a little bit better bioavailability than acyclovir, but acyclovir may be a little bit cheaper. So I think Valtrex 1 gram daily or acyclovir 400 milligrams twice a day prophylactic dose should be used perioperatively for at least 3 to 6 months after mice. So, and again, as I mentioned, this is important because making sure that many of these patients, the vascularization has happened because of herpes simplex or herpes zoster. So using acyclovir or Valtrex is very important. I do also like doxycycline, as you mentioned as well. So I typically just do a low dose of 50 milligrams once a day for females, twice a day for males, or patients who are a little bit larger. And I think that's also very important. not that it's going to treat the vessels, but it's going to decrease some of the inflammation that may happen, especially after surgery, that may cause recurrence of these blood vessels. As far as topical steroids, even before surgery, these patients are typically on steroids once or twice a day topically, like predacetate or fluorometholone. And after mice, we keep them on a 4-3-2-1 taper, meaning 4 times a day for 1 month, 3 times a day for another month, 2 times a day for 1 month, and then staying on once a day almost indefinitely to help prevent recurrence. One of the things which I didn't show, which I've started doing now recently, at the time of surgery, is also giving a subconjunctival injection of bevacizumab. And the idea here is near the area of where the vessels were most prominent. And the idea here is while the mitomycin C is treating the vessels that are in the cornea, as I mentioned, Avastin or bevacizumab won't treat those chronic vessels because they're no longer dependent on VEGF for survival. But by injecting Avastin near the limbus subconjunctivally, the idea would be that if there is now a compensatory or rebound drive for new vessels to form, by putting the anti-VEGF medication there, we're hopefully preventing some of the new vessels or recurring vessels from forming. And the reason I started doing that, as you can see in some of those cases, we do have some recurrence of those superficial or very fine vessels here. So I think your question about making sure the disease state is treated with antivirals, anti-inflammatories, whether it's topical or oral, is very, very important. But I think also now intraoperatively injecting a little bit of subconjunctival Avastin can be extremely helpful. So I hope that answers the first question. As far as the second question you asked, which is about what happens if, God forbid, the mitomycin gets into the eye, into the anterior chamber. And this is one of the reasons I like doing this in the operating room. There are colleagues across the world that are doing this at the slit lamp because, as we know, the optics and the view at the slit lamp is going to be much better than the microscope. But I do this in the operating room, and I have a paracentesis blade available as well as the INA available, the irrigation aspiration available. Thank God it has not gone into the anterior chamber in my hands yet, but I've heard of cases where it has happened. And so the reason I do it in the operating room is because, heaven forbid, if it does get into the eye, I can immediately make a paracentesis, 2 paracentesis wounds, and insert the bimanual INA and irrigate the mitomycin out for however long, 1 to 2 minutes, to make sure that it's not in the anterior chamber, because as we know, that could be very devastating in the eye. So that's one of the reasons I do this in the operating room, even though it's logistically it takes time to set up, and at least in the United States, we don't get paid much for doing this procedure at all, since there's no code. So I do it as community service type of a thing. But I think that's why it's important to do it in the operating room. In my opinion, though surgeons who are doing this in the slit lamp or the minor procedure room have demonstrated good success, I still feel more comfortable that in the rare event that if the mitomycin were to get into the anterior chamber, then you can quickly make 2 paracentesis wounds, insert the bimanual INA and irrigate all of that out to prevent any potential endothelial toxicity.
Professor Kamran, one thing more, that corneal neovascularization, we see it happens in infections, bacterial, viral, after PKP, corneal transplants. But I would like to ask you about chemical burns. When chemical burns happen, there is limbal stem cell deficiency and corneal epithelium get conjunctivalized. So have you ever tried this mice technique in chemical burn neovascularization, and how did it behave?
Yeah, so I have not tried it in that situation, and primarily because the vessels that form in those, due to toxic injury, like chemical injury, alkaline, acid injury, those tend to be those very fine, wispy vessels, more conjunctival vessels, and they're not very amenable to cannulization. Those are patients that ultimately need, treatment for a limbal stem cell with either sequential superficial keratectomy, SLET, KLL, those types of procedures. There's now a new procedure here in the United States called BMAC, or bright membrane anterior keratoplasty, where using a Descemet's membrane can sometimes be done. But to answer your question, I have not tried it in chemical burn injuries, mainly because the vessels that form in that disease state are superficial and very thin and wispy. They're not the deep, fat, juicy vessels that are amenable for cannulization injection of mitomycin. And then the other thing that would make me worried is that in those patients, we already have limbal damage. Then I worry about using mitomycin in those cases where we can further kill off healthy, limbus and healthy stem cells. So I haven't used it, and I don't feel comfortable using it, so I don't plan to use it. But there may be colleagues who have used it and have had some success with it. But personally, just makes me a little nervous to try it in that particular scenario because of those risks that I mentioned there.
Well, I think Professor Kamran has explained corneal neovascularization in detail and its causes and its management, medical, or this surgical, especially this MICE technique. And I hope this will be very beneficial for our ophthalmologists who will also try this technique to control, because this is a really very challenging thing to handle. And Dr. Professor Kamran, I'm extremely grateful that in spite of your very busy schedule, you have given time to us for this presentation. And inshallah, we will be looking forward you on more sessions. So I want to thank you for your presentation. Thank you, Professor Kamran.
You're very welcome. My pleasure. And alhamdulillah, I'm glad this was beneficial. And I can share my contact information if anybody wants to email me or contact me. I'm happy to discuss this further for anybody who watches this video. So, Dr. Mirza, you can include my email, which is basically Kamran, Kamran, then followed by a hyphen or like a minus sign, and then Riaz, R-I-A-Z, so Kamran-Riaz at dmei.org. So that's Dean McGee Eye Institute.org. So Kamran-Riaz at dmei.org. So if anybody wants to email me, I would be happy to answer any questions privately and offline.
I will mention it in the description also in the video, inshallah.
Okay, thank you so much.
Thank you, sir. So nice of you.